The basic principle of intravascular lithotripsy is based on a principle of a vapor being created by an electrical energy and the further propagation of the mechanical waves. So what basically happens in an IVL is, it's not a balloon. Basically, there are two emitters which gives an electrical energy, and you have a fluid-filled balloon where this is converted to acoustic waves, and that is transmitted through this interface into the vessel wall, rupturing the calcium or cracking the calcium rather. So this chart shows a basic principle, and we know that waves have a positive and negative deflection. In an IVL, basically the positive deflection is given more prominence and the negative pressure is reduced. So that gives the efficacy of an IVL balloon. So the electrical emitters give multiple non-focused energy, vapor bubbles, and that gives waves. And at one moment, it gives almost like a 50 atmosphere of equivalent to 50 atmospheres of pressure, and that cracks the calcium. So the important thing is that this balloon should oppose to the vessel wall, and this wave will travel unimpeded through the soft tissue, and this gives compressive stress at sites where there is calcium or the interface between the calcium and the normal vessel wall, and that creates fractures. Both micro and macro fractures have been documented. So one important thing is, this can travel even beyond the stent struts, as in an underexpanded stent, and into the deeper calcium also, creating fractures even there. So this micro CT basically gives a good impression of that fractured calcium. The down one shows these calcium multiple fractures, which makes our job further down easy. Of course, imaging prior is essential. People have talked about imaging, of course, but then what I have noticed in my practice of having done around 20 IVL is that often these catheters don't cross so easily in cases of heavy calcification. So somebody already talked about the detailed chart for calcified lesions. Basically, in an IVL, two things you have to think about is whether it's a balloon crossable lesion or not. If it's balloon crossable, then IVL. Of course, if you use another atheroablative strategy further down the line, if there is still an underexpansion, then also IVL comes into the road. So pre-dilatation is often recommended by people if it's a small 1.5 2 mm balloon, and in the Disrupt CAT 2 trial, almost 30% of cases they had pre-dilatation. The C2 balloon has 80 pulses, we know. 12 mm is the fixed length of the balloon. The sizing is important, 1:1 to the vessel wall. Of course, but there are people who believe that 1:1 in not all cases is acceptable. Like if an eccentric nodular calcium, or if there is an LM to LED, you are doing an IVL, where you have to match to the distal LED, and probably you can use an NC balloon further down the line for the increasing the diameter of the LM. But the important thing is that this balloon should oppose to the vessel wall, and there should not be air, because that will reduce the efficacy of the balloon. So I've told about the calcium modification. Both superficial and deep calcium is modified. And one thing is, if you have more calcium in the vessel, there is more cracks, and that increases the efficiency of this IVL balloon. The chance of vessel perforation is less, basically because this travels unimpeded to soft tissues, and you have an adventitial fibrosis usually in these sort of cases, which prevents a perforation of the vessel. And in CAT study, almost 70% of cases had this fracture. Other cases, they presume it's microfractures, or probably these fractures are out of the imaging plane. And the best lesion, as per description for an IVL, is a downward shade 360 degree or more than 270 degree of calcification. And what they say is, minimum you should give 20 pulses to each lesion. The median number of catheters which were used in the Disrupt CAT studies were 1.2, and 74 pulses were used to crack the lesion on an average. And at 4 atmosphere, you oppose to the vessel wall, and at 6 atmosphere, you increase the balloon compliance and to assess a symmetrical expansion. And of course, deflation is important because the small air bubbles should escape.
Praveen, can you just quickly conclude your lightning?
So air in IVL catheter has to be avoided at all costs. Post-therapy, absence of calcium does not mean you have failed the procedure. It only means it's not imaged. And IVL-induced lumen gain has been clearly shown in all studies with OCT and IVUS. And post-dilatation, incomplete expansion is there, you should do a post-dilatation. If the IVL is also downsized, you should do a post-dilatation. CAT study, almost more than 30% dilatation, and then complications are basically very low, but there are dissections, perforations, and BP reductions, and also shock topics are also documented. And specific situations is used to even in LMC and even ACS with thrombosis.
All right, then, I think we will stop here because
there's a contained rupture, and I will show one case of a balloon rupture where a nodule elegantly produced, this is a nodule, and that produced the balloon rupture of an IVL balloon. I think that's the last slide. Thank you.